Droperidol lovers. I'm looking at you, Dr. Matisse. The Journal of Emergency Medicine looked at droperidol's cousin, haloperidol, maybe you've heard of it, and compared it versus Reglan for treatment of acute headache. They pre-treated each group with 25 milligrams of IV Benadryl, and they gave 10 IV Reglan versus 5 of IV Haldol. They found in the Reglan group, 8 out of 33 patients needed additional pain medication, whereas in the Haldol group, only 1 out of 33 required additional pain medication. They did, however, find that Haldol caused more drowsiness. So, Haldol for acute of a treat headache. The Journal of Trauma and Acute Care Surgery performed an evidence synthesis on open thoracotomies performed in the emergency department. They found that about 20 to 40 out of 1,000 patients per year had some benefit from the open thoracotomy. They are recommending open thoracotomies for penetrating trauma with vital signs loss in the emergency department, as usual. tPA haters, as the hatred grows inside you in the new guidelines for tPA administration, the new AHA and ASA guidelines for endovascular treatment of acute ischemic stroke are out, and the hatred continues to rise. The guidelines based on the ESCAPE, the Extend IA, the Swift Prime, Mr. Clean, among others, have people up in arms. They recommend that treatment for all comers within 6 hours for endovascular intervention, and they discard the tissue-based criteria that they looked at in the studies. So more money for the companies and probably a little less for the patients. There you go. Let's get on with the rest of the show.
Welcome to the 456 EMS show for the awake, alert, and disoriented.
Decompressing a tension pneumothorax with a needle chest decompression can be a life-saving procedure. However, there are significant risks if it's not correctly performed. The first step is to take proper infectious disease precautions. Since this is an invasive procedure, a possibility exists for exposure to the patient's blood. The air in the chest cavity may propel potential infectious material toward the medic. The use of gloves, gowns, eye and face protection are recommended. Next, prepare your equipment. At minimum, you will need a 2-inch 14-gauge over-the-needle catheter, 18-gauge for pediatric patients, antiseptic wipes to clean the site, tape to secure the catheter, and a mechanism for creating a one-way valve. Unless you have access to commercial decompression supplies, the simplest way to construct a one-way valve is to insert the IV catheter into the finger of a glove. Additionally, a 10 milliliter syringe filled with 5 milliliters of normal saline attached to the needle may be helpful. This is especially beneficial in a very noisy environment. Identify the location for needle insertion. Remember, a tension pneumothorax may affect breath sounds on both sides of the chest. Be sure you are on the side of the injury. Find the mid-clavicular line on the affected side. Studies have shown that a significant number of healthcare professionals have difficulty locating the mid-clavicular line and actually insert the catheter medial to the ideal location. This poses significant risk if the needle is inserted into the mediastinum. The midclavicular line is located midway between the midsternal line and the axillary line. To find the second intercostal space, palpate downward until you feel the third rib. The first rib is not palpable since it is behind the clavicle. The space directly above the third rib is the second intercostal space. You may need to apply substantial pressure to feel the ribs on patients with significant soft tissue over the area. Prep the site, then insert the catheter just above the third rib at a 90-degree angle. Once you reach the pleural space, you should hear a hiss as air escapes. Or, if you have attached a saline-filled syringe, you will see bubbles in the fluid. Stop advancing the needle and thread the catheter off until the hub reaches the skin. Remove the needle and secure the catheter with tape. You should note air escaping on exhalation and the glove finger collapsing on inhalation if your one-way valve is working correctly. Observe the patient for improvement. Over time, as air escapes from the thoracic cavity, the patient's respiratory efforts should improve. You may insert additional catheters to speed decompression if your patient's condition warrants. Here are a few more important considerations when performing this procedure. Heavily muscled individuals may require a catheter longer than 2 inches to reach the pleural space. You may use a 3-way stopcock in place of a glove finger, but you will have to open the valve manually to release air on exhalation. Occasionally, the catheter may become obstructed by clotting blood or tissue, so make sure to continuously reassess your patient.